This will be the second in the cycle or the present session today for the Young Physician Forum. Since the competition, we strictly adhere to time. So presenters are supposed to present for only 25 minutes, and then there should be a 5-minute question time. And the session is sponsored by CIPLA. In addition to EM Vijayaram Award, they give away 3 merit awards, which will be awarded during the annual session next year. So to start the proceedings today, I would like to call upon our first speaker, Dr. Pemini Rajapaksa, Senior Registrar in General Medicine, North Colombo Teaching Hospital. She will be talking to us amyloidosis, a multifactorial masquerader. Over to you, Pemini.
Thank you, sir. And a very good morning to all of you. I am Pemini, a Senior Registrar in General Medicine, currently attached to North Colombo Teaching Hospital. So, amyloidosis, a multifaceted masquerader. As the name implies, let me take you through this heterogeneous disorder and its multiple presentations. Let me begin with the case presentation. And this is based on an interesting patient whom we encountered recently in our ward. He was a 40-year-old male. He was a previously unevaluated patient, and he presented with a gradual worsening of shortness of breath and bilateral lower limb swelling for 2 weeks duration. And at the time of presentation, his shortness of breath had increased to a point that he could not carry the activities of daily living, and his lower limb swelling was up to upper calf levels. And there was intermittent frothy urine, which patient had noted, and the latter stages, there was periorbital swelling. And he also had a significant loss of appetite and fatigue, but there was no other systemic features. In the background, patient did not have any features to suggest any autoimmune rheumatological disorders like inflammatory type joint pains, and he was a teetotaler, and he did not smoke, and he denied any intravenous drug abuse or denied any unsafe sex practices. He was not pale on examination, and he was not dipteric. His jugular venous pressure was elevated with a pulse rate about 80, and blood pressure was 100 by 16 bilateral upper limbs without a postural drop. His apex weight was not deviated. The first and second heart sound was normal, and there were no S3 gallop rhythm or murmurs. His respiratory rate was 20 per minute with bibasal crepitations. So, at the end of the history and examination, in one hand, our patient had predominant features of heart failure, and on the other hand, he had features of renal involvement. So, in other words, we were thinking of differential diagnosis for cardiorenal syndromes. So, even though this term, cardiorenal syndrome, has been there for about some time, the nomenclature was described first by Claudio and his colleagues in the Journal of American Cardiology in 2008. There are 5 types. Type 1 is when acute heart failure causes acute kidney injury. Type 2 is where chronic heart failure causing chronic kidney disease. Chronic activation of renin-angiotensin-aldosterone mechanism is implicated. And type 3 is where an abrupt primary renal dysfunction, as in the case of glomerulonephritis, causing this disease. And type 4 is a primary kidney disease causing heart failure. And type 5 is when an acute or chronic systemic disease leading to both cardiac and renal dysfunction, as in the case of diabetes, sepsis, or amyloidosis. So in our patients, we thought types 1, 3, or 5 were possibilities. This is his full blood count revealed a moderate anemia with moderate Rouleau formation, and his renal functions were gradually worsening, and he had albumin globulin reversal with evidence of albuminuria in the urine. Interestingly, patient's ESR level was very high with a normal CRP value. And then we strongly suspected the diagnosis of systemic lupus erythematosus. but his anti-nuclear antibody level and double-stranded DNA antibody levels were negative. And in the background, his tubercular screening and initial myeloma screening with calcium level and X-rays were normal, but we sent a serum protein electrophoresis. And his ultrasound scan abdomen revealed only a acute kidney injury. And his ECG revealed some lateral T inversions. But in the 2D echocardiogram, there was concentric left ventricular hypertrophy, which we performed bedside. But his ejection fraction was more or less normal. So we were at a diagnostic dilemma. This patient had a left ventricular hypertrophy in the echo, but he didn't have any voltage criteria in the ECG. So then we were thinking of possible infiltrative processes going in the heart. So with these patients, albumin globulin reversal, moderate relay formation anemia, and with the renal involvement and cardiac involvement, we thought amyloidosis with an underlying plasma cell disorder would be a high possibility. And in the background, other important diseases of infiltration was also screened. So when we asked for a departmental 2D echocardiogram, it revealed the typical features of cardiac amyloidosis. There was a pericardial effusion with uniform thickening of septum and interventricular walls. And when you look closely, you can appreciate the typical speckled appearance of amyloidosis. This was once thought to be very characteristic, but now due to hormonal 2D echocardiogram images, it is not so. And he had biatrial enlargement due to restrictive cardiomyopathy, and his ventricular walls were small. When we performed the strain imaging, it revealed the characteristic features of amyloidosis of reduction of global longitudinal strain, and there was relative apical sparing pattern, which is very sensitive and specific in diagnosis of cardiac amyloidosis. And I hope you can appreciate the dark red area in the middle, which is relative apical sparing. It is called the cherry on top appearance due to its typical appearance like a cherry on the top of a pie. So when we performed the serum protein electrophoresis, it revealed a monoclonal band in the gamma region, but his lambda chains were excess with a kappa restriction. And we went ahead with the abdominal fat pad aspiration, but it was negative. But in the bone marrow, 72% of plasma cells were there with monoclonal paraproteinemia. And so in the surrounding tissues, there was a eosinophilic hyaline material which stained salmon pink under Congo red. And it gave an apple green birefringence under polarized light. So a diagnosis of amyloidosis was confirmed. His renal biopsy recently was performed and we are awaiting the results. And here is the typical salmon pink appearance, which was shown in the bone marrow of our patient. And there were abundant plasma cells. So finally, multiple myeloma and secondary AL amyloidosis with cardiorenal involvement was diagnosed. Amyloidosis is a heterogeneous disorder of protein misfolding. These misfolded proteins deposit in various extracellular tissues and organs and give rise to varied manifestations. So it can present in disguise as a simple carpal tunnel syndrome, to a heart failure with preserved ejection fraction, to a neurodegenerative disorder. Hence, it's a multifaceted masquerader. The term amyloid was first described by Sir Rudolf Virchow, who was a German pathologist, and he thought this deposit was seen as starch. So the name, the starch in Latin is called amylum, hence the name amyloidosis. There are about more than 30 proteins described in the pathogenesis of amyloidosis. According to the tissue and the organic deposits, it can give rise to a systemic disease or a localized disease. So, beta amyloid protein causing Alzheimer's disease, prion protein causing Creutzfeldt-Jakob disease or spongiform encephalitis is a localized form of CNS amyloidosis. And this amyloidosis occurs due to normal production of an abnormal amount of proteins, as in the case of ALO, AA amyloidosis, or production of normal amounts of a mutant protein, as in the case of ATTR amyloidosis. these protein monomers configure into antiparallel beta-pleated appearance, which are very resistant to degradation. So they deposit in various tissues and give rise to varied manifestations of amyloidosis. So the AL amyloidosis is the commonest type of amyloidosis, followed by ATTR and AA. So this is a recent article published in New England Journal of Medicine describing the recent change in epidemiology of amyloidosis. So in the bar chart, blue color represents the total cases of amyloidosis. So it had, within the past 3 decades, it had improved drastically. So this implies the increased awareness and modern diagnostic available to detect this disorder. And in yellow color, AA amyloidosis is shown, and the number of cases has been less during the past few years. This is mainly due to novel biologics and treatment modalities available for the inflammatory disorders like rheumatoid arthritis and systemic lupus erythematosus. So these are the varying clinical manifestations of amyloidosis. Macroglossia and periorbital purpura are very characteristic and diagnostic of systemic AL amyloidosis. So in the diagnosis of amyloidosis is of fourfold. First, we have to confirm the diagnosis of systemic amyloidosis by doing a tissue biopsy, and then mass spectrometry or immunohistochemistry for the typing of amyloidosis can be done when the facilities are available. And search for monoclonal immunoglobulin is important because AL amyloidosis is the commonest type of amyloidosis. And imaging and blood testing can be performed to see the extent of involvement of the organs. So for the definitive diagnosis, tissue biopsies are needed. So in systemic amyloidosis, it can be done from organ involved or from a site where most probably amyloid deposits can be seen. For an example, abdominal fat pad biopsy, minor salivary gland biopsies, and rectal mucosal biopsy can be performed. And I have already described the histopathology. And this point I have to stress. Unlike in multiple myeloma, the light chain burden is very less in systemic AL amyloidosis primary form. So the traditional serum and urine electrophoresis will be less sensitive. Immunofixation studies and serum-free immunoglobulin light chain assays should be performed. So when we found that our patient had cardiac amyloidosis, we were searching for Sri Lankan literature, but our attempts were futile. But there were a growing number of cases reported from the West, especially worldwide. This disorder has transformed from an incurable, untreatable disorder to an easily diagnosed, treatable disorder. So one study done at Mayo Clinic, autopsy study done from 109 patients, more than 75 years of age, died of heart failure with preserved ejection fraction, revealed that about 1/3 of them had cardiac amyloidosis. And in another Spanish study of multicenter hospitalized patients, it revealed that in about 10 to 15% of patients with heart failure with preserved ejection fraction who were more than 60 years had cardiac amyloidosis. And this is just a tip of the iceberg. So as clinicians, it is important to know the presentation, novel diagnostics, and treatment modalities available for this disorder. So cardiac amyloidosis comprises of main 2 types, ATTR and AL. ATTR accounts for more than 80% of cases. So the mutation can be acquired genetically, then it is called hereditary or variant. And if it is acquired during old age, it is called, previously it was called senile. Now the name has changed into a wild type, probably a more attractive name. So they can present with predominant features of cardiac failure, and also they can present with syncope or pre-syncope due to arrhythmias, due to conduction tissue involvement, but angina is an uncommon feature. So there are some unique extracardiac features of amyloidosis, especially ATTR amyloidosis. It can present with bilateral carpal tunnel syndrome, spinal stenosis due to ligamentum flavum deposition of these amyloid fibrils with radiculopathies, and they can cause a spontaneous bicipital tendon rupture. This is shown in this image, and it is also called Popeye muscles. Popeye muscle. I'm sure he was one of your childhood heroes, as he was mine. And typical ECG pattern is low voltage complexes with pseudoinfarct pattern, but it is not the case in all the patients. It was not seen in our patient. Disproportionate voltage criteria, as I already described, is highly suggestive. And there are no specific lab diagnostic tests to diagnose ATTR amyloidosis. And I already described the 2D echo in the importance of 2D echo in diagnosing amyloidosis. Typical longitudinal strain impairment is a suggestive, very highly suggestive feature. And cardiac MRI is one of the key diagnostics of AL amyloidosis as well. So it can detect amyloidosis even before left ventricular hypertrophy occurs. Subendocardial late gadolinium enhancement, and in later stages, global uniform transmural late gadolinium enhancement are very highly sensitive and specific features of cardiac amyloidosis. And technetium PYP or pyrophosphate bone scintigraphy has been a game changer in diagnosing ATTR amyloidosis. So usually this tracer is taken up only by bone tissue. But in ATTR amyloidosis, there are microcalcifications within the amyloid fibrils. So the tracer is taken by the heart tissue as well. So as shown in this graph, grade 2 or 3 uptake by the heart, which is more or less equal to the bone, is almost diagnostic of ATTR amyloidosis. And unless olden days, endomyocardial biopsy is not a must in diagnosing of cardiac amyloidosis. And in the case of ATTR amyloidosis, other tissue biopsy sites will have a low sensitivity because it is more of a localized disease of the heart. And presence of grade 2 or 3 positive bone tracer by technetium PYP scan and absence of monoclonal proteins are diagnostic of ATTR amyloidosis. And CMR features and previous detection of AL amyloidosis will be diagnostic of AL amyloidosis. So when do we have to suspect that a patient is having amyloidosis? In a patient with unexplained left ventricular hypertrophy, even without hypertension, and in patient with a diagnosis of heart failure with preserved ejection fraction with an unexplained left ventricular hypertrophy, and in patients with low-grade aortic stenosis with echo features suggestive of amyloidosis, and especially in patients over 60 years who are first-time diagnosed with hypertrophic obstructive cardiomyopathy. So hypertrophic obstructive cardiomyopathy or HOCM causes mainly asymmetrical septal thickening. But in the case of most cases of amyloidosis, there will be a uniform thickening of biventricular walls and the septum. So when diagnosing, when we have a clinical suspicion with a history examination and investigations, we have to perform immunofixations and serum-free light chain assays, as I've mentioned before, because the commonest form of amyloidosis we see is AL amyloidosis, even though it accounts for only about 2% of cardiac amyloidosis. And if the labs are abnormal, we have to proceed as in the case of AL amyloidosis. But if the labs are normal, we have to perform a technetium PYP scan. A grade 2 or 3 uptake would be diagnostic of ATTR amyloidosis. But a grade 1 uptake, when there's a grade 1 uptake, maybe we have to go ahead with endomyocardial biopsy. So the management of amyloidosis comprises of twofold, which is heart failure management and amyloid-specific therapy. So the traditional heart failure management medications, like moderate benefit medications, are not beneficial and tolerated by these patients because they already have a restrictive cardiomyopathy, which reduce the ventricular filling. And their cardiac output would mainly be maintained by heart rate. So when we give beta blockers or calcium channel blockers, the heart rate response will go down. So further reducing the further reducing the cardiac output and reducing the systolic blood pressures. So they will be intolerable. Actually, calcium channel blockers are contraindicated. The mainstay of treatment are loop diuretics and aldosterone receptor antagonists. And digoxin can cause toxicity even in normal concentrations because they can be kept trapped by these amyloid fibrils. And atrial fibrillation is common due to conduction tissue abnormalities. And irrespective of the CHA2DS2-VASc score, they should be anticoagulated because they have already dilated atria and more prone for thromboembolism. And in the case of ATTR amyloidosis, liver heart transplantation can be done, but is rarely performed. And when coming into amyloid-specific therapy, the novel treatment, daratumumab, an anti-CD38 monoclonal antibody, has drastically improved the prognosis of AL amyloidosis patients. Usually, the amyloid protocols are taken up from multiple myeloma protocols. So, usually, Cybody or cyclophosphamide, bortezomib, dexamethasone is used as the first-line therapy. But this Andromeda trial revealed addition of daratumumab to normal treatment regime improved the complete hematological response up to 53%. It was just 18% in the traditional treatment group. And in case of ATTR amyloidosis, once thought a disease which was incurable. Now there are so many treatment modalities available, and there is ample research going on in this area. And usually ATTR transthyretin is secreted as a tetramer from the liver. So in case of ATTR amyloidosis, these tetramers dissolve into monomers and then they form amyloid fibrils and then they deposit in various tissues and cause amyloidosis. And in this tetramer, there are another treatment which silence the mRNA and also which are tetramer stabilizers. The only FDA-approved drug is tafamidis, which is a tetramer stabilizer, and it had drastically improved the prognosis in these patients. And there are novel treatment regimes where they act at the mRNA level to reduce formation of the mutant protein. One such drug is patisiran. This is ATTR ACT study, which shows that the patients who were treated with tafamidis had an all-cause mortality benefit than patients who were treated with placebo. And it also showed that there's an improved reduction of hospitalization and improvement of 6-minute walking test among these patients. So all these novel therapeutics have improved the prognosis of the cardiac amyloidosis patients from few months to more than 5 years. And this graph shows my prognostic staging system for AL amyloidosis, which includes troponin levels and brain natriuretic peptide levels. So coming back to our patient, and actually it was a multidisciplinary team approach with active input from hematology, cardiology, and nephrology teams. First, patient was started on myeloma-based therapy with triple therapy of bortezomib, dexamethasone, and lenalidomide, and his heart failure and low blood pressure was symptomatically managed with intravenous diuretic under inotropic support. We all know multiple myeloma is a immunopathic condition. So our patient went into right lower zone pneumonia and there was empyema which warranted him to stay in ICU for several weeks. And at that time, patient went into acute kidney injury where several episodes of hemodialysis were given. Intravenous albumin and ultrafiltration was used for refractory edema. And currently, he is clinically improved and heart failure improved with diuretics and ultrafiltration, and he's not dialysis dependent. And thereafter myeloma-based therapy, there is an undetectable MBAN. Now, currently, he is on Cybody treatment, which I already mentioned, with doxycycline. We use doxycycline because there are some trials which show the improvement of symptoms with doxycycline in phase 2 and 3 trials. So in summary, ladies and gentlemen, amyloidosis is not a rare but clinically neglected, underdiagnosed disease. And in fact, it can come in disguise in various shapes and forms. In fact, it's a multifaceted masquerader. And clinical awareness and high degree of suspicion is important as clinicians. Cardiac amyloidosis has transitioned from an incurable rare disorder to an easily recognizable and a treatable disease over recent past few years. These are my references. And a huge thank you goes to Ceylon College of Physicians for this great opportunity to present to this prestigious audience. My sincere thanks goes to my MD trainers, Dr. Deepa Amarasekara, Dr. Jayasekara, for their immense support in making this presentation and managing our patient. And my amazing group of registrars, house officers, senior house officers, and rest of the staff at CNTH, I thank all. And it would be a great privilege for me to thank Dr. Yasinta Costa, Dr. Tanuja Disanayaga, consultant hematologist and team, Dr. Sanjeeva Rajapaksa, Dr. Janat P. Gunasinghe, consultant cardiologist and the team, Dr. Dinit Kalabadi, consultant nephrologist and the team, for their immense support in managing our patient. And I thank my pre-MD trainers, Dr. Kuldisanaka, Dr. Nandini Madhuvada, for their immense guidance and support throughout. And my bosses during internship, Professor Saman Gunathilaka, Professor Jayendra Kumar, Dr. Ajanta Aliyanage, Professor Kamani Vanigasuriya, Dr. Sanjeev Vijaypon, and Dr. Samir Marasinghe. Thank you, sirs and madams. And I thank all my senior registrars and registrars who are a constant inspiration for me. And I thank our patient at last for having faith on us and having patience with us. And ladies and gentlemen, thank you very much.
It's open for questions now. Any questions? The audience? These treatment models are available and the diagnosis ones and treatment are available in this country at the moment.
Yes, thank you for that good question, sir. Actually, electrocardiogram and LV patterns can come in our patient. And cardiac MRI is available in National Hospital of Sri Lanka and also in the private sector. And technetium pyrophosphate scan is not yet available. Even though technetium scans are available, pyrophosphate is not used in Sri Lanka at the moment. And therapeutics wise, daratumumab is available in the private sector, which is costly, but we know patients who have undergone treatment and who have improved with that. And when we search into this data, we found out, but other treatment modalities are actually now in the West as well, worldwide. So yeah, yet to improve the awareness and the diagnostic and therapeutics of this disease. So thank you for the question.